Welcome to the deep dive. Think of this as your fast track to really grasping the stuff that matters. Today we're zeroing in on systemic sclerosis, or scleroderma. If you've got revision notes on this, you probably know it can be a beast to wrestle with.
Hmm.
We've taken those detailed notes, and our aim is really to extract the core knowledge, the bits that will actually stick in your mind and be useful.
Exactly. Yeah, medical information can feel pretty overwhelming, can it? And our goal here is to make systemic sclerosis, well, understandable, memorable, and genuinely helpful for your revision. We're going to explore it from its very definition right through to how it's diagnosed, managed, and what the potential outcomes are.
Okay, so let's dive straight in systemic sclerosis, or SSc. It's a chronic autoimmune disease. The crucial thing, I think, to understand is that the body's immune system goes a bit haywire and starts producing way too much collagen.
Yeah, that's the core problem. And
Right.
this leads to fibrosis, essentially scarring not just of the skin, which we often think of first, but also vital internal organs. We're talking blood vessels, the entire GI tract, lungs, heart, even the kidneys.
Wow. Okay, so it's truly systemic.
It really is. And the engine driving this process is increased activity of cells called fibroblasts. These cells normally produce connective tissue, but in SSc, they become overactive for reasons we'll get into.
Right.
This overactivity results in that abnormal buildup of connective tissue, damage to the delicate blood vessels, and that characteristic fibrosis. It's important to keep in mind some key vascular things that pop up. Secondary Raynaud's phenomena, which affects blood flow to the fingers and toes.
The color changes.
Actually.
Yeah.
Then pulmonary arterial hypertension, a really serious lung condition, and potential kidney involvement, too.
What struck me immediately when reading the notes was the gender skew. It's much more common in females.
Definitely.
And the name itself, scleroderma, literally hard skin, gives you a really direct visual for one of the key features, doesn't it?
It absolutely does. A very descriptive name.
Now, our notes break down SSc into different types, which seems pretty fundamental to getting a handle on it.
Absolutely critical. The two main classifications you really need to know are limited cutaneous systemic sclerosis, often shortened to lcSSc,
lcSSc, got it.
and diffuse cutaneous systemic sclerosis, or dcSSc. The cutaneous part tells you it involves the skin, and limited versus diffuse refers to how widespread that skin involvement is.
Okay.
Beyond those two, there are also other forms like overlap SSc, where patients have features of SSc plus other connective tissue diseases, and then there's systemic sclerosis signs scleroderma,
Signs scleroderma meaning?
without scleroderma. So
Okay.
the internal organs are affected by that sclerotic process, but without the typical skin hardening you'd expect. More unusual, that one.
Right, that must make diagnosis tricky sometimes. So what actually sets this whole chain of events in motion? What's the etiology, the underlying causes?
Well, like with many autoimmune diseases, the precise cause of SSc remains unknown. It's thought to be a really complex interplay between a person's genetic makeup, environmental exposures, and the way their immune system functions.
Okay.
We see three key factors consistently involved: that excessive collagen production we mentioned, the damage to the blood vessels, and the activation of the immune system leading to autoantibodies. These are antibodies that mistakenly target the body's own tissues.
Right, the autoantibodies. And what about the actual triggers? Our notes mentioned quite a few things implicated.
Yes, exactly. There's a whole range. Genetic predisposition, for one. So some people might just inherit genes that make them more susceptible.
Makes sense.
Certain infections, maybe cytomegalovirus, have been suggested as potential triggers. Exposure to specific chemicals, like organic solvents, and even certain drugs, cocaine, for example, have been linked.
Interesting mix.
Yeah, and then things like radiation exposure, physical trauma, and even potentially lower levels of vitamin D have also been noted as possible contributing factors. So it's a broad picture, suggesting multiple potential pathways might lead to the disease.
That is quite a diverse list. So who is statistically more likely to develop SSc? Let's look at the risk factors.
Well, the key risk factors largely mirror what we just discussed about etiology.
Right.
Being female is a significant risk factor given that higher prevalence.
Right.
Certain genetic variations can increase susceptibility. Having a family history of SSc also raises the risks, suggesting that heritable component.
Okay.
Environmental exposures, particularly to things like silica dust and organic solvents, are recognized risk factors. And finally, certain viral infections have also been linked to an increased risk.
Okay, so we've got the definition, potential triggers, and who's more at risk. Now let's dig into the mechanics. How does systemic sclerosis actually work at a biological level? What's the pathophysiology?
So the core of the pathophysiology lies in the activation of the immune system. which unfortunately kicks off this cascade leading to tissue fibrosis. It's this abnormal and excessive deposition of collagen protein that causes the characteristic thickening and hardening of the skin and those internal organs we've talked about.
Right, the collagen buildup.
Exactly. And critically, abnormalities in the blood vessels and ongoing inflammation play a really significant role in driving the tissue damage and the eventual dysfunction of the affected organs. It's kind of a self-perpetuating cycle. Immune activation, vascular damage, fibrosis.
This sounds like a condition that could potentially be mistaken for other diseases with similar symptoms. What's in the differential diagnosis? What else might look like this?
That's a crucial point for getting the diagnosis right. Several conditions can present with overlapping features. Our notes list things like systemic lupus, erythematosus, SLE, rheumatoid arthritis, RA, polymyositis, and dermatomyositis as important ones to consider.
Okay, other autoimmune conditions mainly.
Yeah, and also various causes of Raynaud's phenomenon, which can occur on its own, need ruling out. Vibration injury, maybe from certain jobs, other connective tissue diseases that might look a bit like RA or SLE, undifferentiated connective tissue disease, amyloidosis, chronic graft versus host disease after transplants, and even some paraneoplastic syndromes, conditions linked to an underlying cancer, can sometimes mimic SSc. So it really highlights the need for a careful, comprehensive evaluation to actually land on the correct diagnosis.
Absolutely. So how common is systemic sclerosis then? Let's talk epidemiology. Who gets it and where?
Okay, so in the UK, the estimate is around 50 to 100 cases per million people. It's most often diagnosed in people between 30 and 50 years old.
That age range, okay.
Globally, SSc is found in all ethnic groups, but its prevalence varies quite a bit geographically, maybe 30 up to 240 cases per million. We see higher rates in North America, Australia, definitely in women, and in people of African descent.
Interesting regional patterns.
Yeah. And while SSc can start at any age, the peak onset is typically between 40 and 50. And it's worth remembering, it is relatively rare in children.
Okay, so we've laid the groundwork. Now let's get into how systemic sclerosis actually shows up in patients. What are the telltale signs and symptoms? The clinical presentation.
Right, the presentation can be quite varied, but there are some general features that often raise suspicion. Raynaud's phenomenon, where the fingers and toes change color, white, then blue, then red, with cold or stress. That's frequently one of the very first symptoms.
Often the first sign, yeah.
Hardening of the skin, particularly hands or face, is another key indicator. And in the early stages, patients might just have more nonspecific things like fatigue, muscle and joint pains, maybe some swelling in the hands.
And then we come back to those two main subtypes. Limited and diffuse cutaneous SSc. How do they typically present differently?
Good question. With limited cutaneous SSc, lcSSc, it's generally a milder form. The skin involvement is less extensive, mainly affecting the skin of the face, forearms, and lower legs. Onset and progression tend to be slow.
Slower pace, okay.
It used to be called CREST syndrome, which is actually a really useful mnemonic for remembering its key features. Calcinosis, Raynaud's, esophageal dysmotility, meaning swallowing problems, sclerodactyly, which is finger thickening, and telangiectasia, those little visible blood vessels.
Ah, CREST. That is a great memory aid. Calcinosis, Raynaud's, esophageal, sclerodactyly, telangiectasia. Got it.
Exactly. And the crucial thing about lcSSc is sometimes it can be around for a long time and maybe even go unnoticed until internal complications, particularly pulmonary arterial hypertension, suddenly appear.
Right, so the skin might be limited, but internal problems can still develop later on.
Precisely. Now, diffuse cutaneous SSc, dcSSc, tends to have a more rapid onset. The skin thickening involves larger areas, upper arms, thighs, trunk, as well as hands and face. The skin changes can spread quite quickly.
More widespread and faster.
Yes. Interestingly, the skin thickening often peaks within the first 3 to 5 years, and then it might enter a more stable phase. However, and this is important, internal organ involvement is more common and often more severe in dcSSc. And unfortunately, there's a higher risk of mortality with this form compared to lcSSc.
Okay, higher risk with diffuse. So let's break down the specific symptoms further. Our notes had a mnemonic idea for skin features. Hard cat, hyper DIRI, hair. Can you walk us through that one?
Sure. So hardening and thickening of the skin, often limiting joint movement, alterations in appearance, Raynaud's, and digital ulcers, those painful sores.
Okay, heart.
Then cat calcinosis, those chalky deposits under the skin. Tightening of facial skin, which can lead to microstomia, a small mouth opening.
Got it.
Then hypo, and hyperpigmentation, changes in skin color, patches of lighter or darker skin.
Right.
DRY refers to dry or itchy skin. And hair indicates reduced hair growth over affected skin areas. And don't forget that initial swelling of fingers and toes, often a non-pitting edema.
Hard cat, hyper dry hair? That's actually quite effective for remembering the key skin signs. What about the musculoskeletal system? How's that affected?
Yeah, musculoskeletal features are common. Things like joint pain and swelling, muscle pain, myalgia. Patients can get significant restriction in joint movement because of the skin tightening and fibrosis around the joints, which can lead to contractures.
Like fixed joints.
Yeah, essentially.
Yeah.
Muscle weakness and atrophy can also happen. And sometimes on examination, you can actually feel tendon friction rubs a kind of grating sensation when tendons move, indicating inflammation.
Okay. Now, the gastrointestinal system seems really heavily involved. Another mnemonic idea here. Heartburn over gastric reduced constipation obstruction anorectal. Let's unpack that.
Right, starting top down. Heartburn covers heartburn and reflux esophagitis inflammation from stomach acid. Over gastric relates to esophageal scarring and dysmotility, leading to dysphagia, difficulty swallowing, and also delayed gastric emptying, making people feel full quickly.
Okay, esophagus and stomach.
Yeah, and also gastric antral vascular ectasia, or GAVE, sometimes called watermelon stomach because of how it looks on endoscopy. That fits there too.
Watermelon stomach, wow.
Then reduced small bowel motility can cause bloating, malabsorption, diarrhea. Conversely, constipation can happen due to reduced colonic motility.
So problems at both ends of the spectrum?
Exactly. More severe issues can include bowel obstruction and pseudo-obstruction, and rarely perforation. And finally, anorectal dysfunction can mean things like fecal incontinence or rectal prolapse.
That sounds like a really wide range of debilitating GI issues. Moving to the lungs, the mnemonic is fibrosis, hypertension, dyspnea, cough, crackles.
Yes, fibrosis is pulmonary fibrosis, or interstitial lung disease, ILD, a major complication. Symptoms include exertional dyspnea, shortness of breath with activity, a dry cough, and crackles heard in the lungs.
ILD. Okay.
Hypertension here specifically means pulmonary arterial hypertension, PAH, where blood pressure in the lung arteries is abnormally high. PAH also causes exertional dyspnea, sometimes fainting or syncope, and signs of right heart strain.
And PAH is particularly serious, you mentioned.
Extremely serious. High mortality rate associated with PAH and SSc. Other lung issues can include aspiration pneumonia, respiratory muscle weakness, even a collapsed lung, pneumothorax.
Okay. And the heart, mnemonic. Micro, accelerated MIO, pericarditis, arrhythmias, sendo, PAH.
Right. Micro is microvascular coronary artery disease, affecting the heart's tiny blood vessels. Accelerated highlights the increased risk of accelerated atherosclerosis and coronary heart disease. MIO is myocardial fibrosis, scarring of the heart muscle.
Scarring the heart muscle itself, okay.
Pericarditis is inflammation of the sac around the heart, sometimes with fluid buildup and effusion. Arrhythmias and conduction defects, irregular heartbeats can occur. Endo refers to endocarditis, inflammation of the heart's inner lining. And PAH reminds us cardiac changes can happen because of pulmonary hypertension or severe systemic high blood pressure. Also, left ventricular systolic and diastolic dysfunction problems with the heart pumping and relaxing can be present.
Lots of potential cardiac impacts. Lastly, the kidneys. Mnemonic. Glomerulonephritis, reduced crisis hypertension failure.
Yep. Glomerulonephritis is a specific type of kidney inflammation linked to certain SSc antibodies. Reduced indicates a decline in overall renal function, maybe with protein in the urine, proteinuria or microalbuminuria. Crisis is the big one. Scleroderma renal crisis. This is a serious emergency. Sudden onset of accelerated hypertension, high blood pressure, which can rapidly lead to acute renal failure.
Renal crisis sounds critical.
It is. That's why regular, careful blood pressure monitoring is absolutely essential for everyone with SSc.
Got it. And just quickly, the notes mention genitourinary features too.
Yeah, briefly. Erectile dysfunction in men, often due to the vascular changes, and dyspareunia, painful intercourse in women, which can be related to skin tightening and dryness in the genital area.
Okay, so given this huge spectrum of potential clinical features, how do we actually diagnose systemic sclerosis? What are the key investigations?
Right. Diagnosis involves putting together the clinical picture, the signs and symptoms with various investigations, mainly blood tests and sometimes imaging. Antibody testing is really a cornerstone.
The autoantibodies again.
Exactly. Anti-nuclear antibodies, ANA, are positive in most cases, maybe 90%. Rheumatoid factor can be positive at about 30%, though it's less specific. But the really key ones are the SSc-specific autoantibodies.
Okay, let's focus on those. Our notes highlighted a few really important ones with memory tips.
Yes, absolute crucial for revision. First, anti-topoisomerase 1 antibody, also known as anti-CL70. This one's strongly linked to diffuse cutaneous SSc,
Diffuse, okay.
and it carries a higher risk of lung fibrosis and renal disease. Generally indicates a more severe course and poorer prognosis. So the memory tip, CL70, severity lungs kidneys.
CL70, severity lungs kidneys, good one. What's next?
Anti-centromere antibody, ACA. This is mainly found in limited cutaneous SSc.
Limited form.
Yeah. It's associated with an increased risk of pulmonary arterial hypertension, PAH. But interestingly, it seems to offer some relative protection against significant lung fibrosis and kidney problems. So remember, centromere, limited, more PAH, less fibrosis kidney.
Centromere, limited, more PAH, less fibrosis kidney. Excellent. And the third key one?
Anti-RNA polymerase III antibody. This one's also linked to diffuse cutaneous SSc and an increased risk of kidney involvement, particularly that scleroderma renal crisis.
Okay, pull a third in kidneys.
But interestingly, often associated with a relatively lower rate of interstitial lung disease compared to Sclerosis. So a memory aid could be polymerase III, diffuse, kidney focus.
Polymerase III, diffuse, kidney focus. Those mnemonics are genuinely helpful for keeping them straight. Are there other antibodies we should be aware of?
Yes, there are several others found in some patients, maybe less specific or seen in overlap syndromes. Things like anti-fibroblast antibody linked to higher risk of heart involvement, PAH, fibrosis, kidney issues, myositis.
Okay.
Anti-Thado and anti-Rho52 TRAM21 associated with increased risk of interstitial lung disease, with Rho52 may be indicating poor prognosis. Anti-E11U12 RNP also linked to ILD. Anti-PMCL often suggests overlap with polymyositis or dermatomyositis, and anti-U1 RNP is more common in mixed connective tissue disease but can pop up in SSc too.
Right, so a whole panel might be relevant depending on the clinical picture. Beyond antibodies, what other tests are used?
Well, general blood tests are important. Full blood count, inflammation markers like ESR and CRP, baseline kidney and liver function tests. Urine protein assessment to check kidneys.
Standard stuff.
Yeah. And nail fold capillaroscopy is very useful. It's non-invasive. You just look at the tiny blood vessels at the base of the fingernails under magnification. SSc often causes really characteristic abnormalities there, especially helpful if someone has Raynaud's or puffy fingers.
Nail fold capillaroscopy.
Okay, hand x-rays might show calcinosis. Thermography can sometimes assess Raynaud's severity. And if GI symptoms are bad, endoscopy or barium studies might be needed.
And ongoing monitoring seems absolutely key.
Totally crucial. Depending on the initial findings, symptoms, and antibody profile, investigations are tailored. Regular kidney function tests, maybe BNP levels for cardiac strain, lung function tests, high-resolution CT scans of the chest for ILD, ECGs, echocardiograms, sometimes cardiac MRI.
Wow, lots of potential monitoring.
Yeah, and for GI stuff, maybe esophageal manometry, 24-hour pH studies, endoscopy, hydrogen breath tests for SIBO, small intestinal bacterial overgrowth.
So how does all this clinical and investigative information actually lead to a formal diagnosis?
Well, early diagnosis is the goal. There are established diagnostic criteria. A major one is skin thickening that extends proximal to the MCP joints, the main knuckles of the hands.
Skin thickening beyond the fingers, essentially.
Exactly. Other big indicators are sclerodactyly, digital pitting scars or pulp loss on fingertips, and bilateral basilar pulmonary fibrosis on imaging. The 2013 Acreeler classification criteria use a scoring system, a score of 9 or more points towards SSc.
Scoring system, right?
Yeah. And interestingly, that skin thickening proximal to the MCPs is actually sufficient on its own to meet the criteria. It carries the highest weight. Other weighted features include finger skin thickening, fingertip lesions, telangiectasia, abnormal nail fold capillaries, PAH, ILD, Raynaud's, and those SSc-related autoantibodies.
It pulls everything together. And there was mention of an initiative for very early diagnosis.
Yes, the VITOS initiative, very early diagnosis of systemic sclerosis. It aims to catch SSc much earlier. Key features raising early suspicion include having ANA, having SSc-specific antibodies, seeing that typical SSc pattern on nail fold capillaroscopy, and having puffy fingers in someone who also has Raynaud's. Recognizing these early signs is vital for starting intervention sooner.
Makes perfect sense. Okay, so we've covered a huge amount. Definition, causes, risks, pathophysiology, differentials, epidemiology, clinical features, investigations, diagnosis. Now the crucial part, management. How is systemic sclerosis treated?
Management is definitely complex. It absolutely needs a multidisciplinary team, rheumatologists with SSc expertise, plus organ specialists like cardiologists, pulmonologists, gastroenterologists, physiotherapists, occupational therapists are vital too.
Team effort.
Big time. The main goals are symptom control, preventing complications, providing supportive care to boost quality of life. This includes patient education, physio for mobility, definitely stopping smoking, maintaining a healthy weight, nutritional advice. Skincare is important. Regular emollients, maybe topical steroids or antihistamines for itch.
And managing Raynaud's.
Yeah, keeping warm, gentle arm exercises, medications like calcium channel blockers are first line. Sometimes SSRIs or alpha blockers are added. Occupational therapy helps with adapting daily tasks. Camouflage makeup or laser can help with telangiectasias cosmetically.
Okay, that's the general supportive side.
Correct.
What about treatments targeting the actual disease process? Immunotherapy.
Yes, for some patients, especially those with early diffuse disease that's progressing, immunosuppressive drugs might be considered. Things like methotrexate, mycophenolate mofetil, or cyclophosphamide, trying to dampen down that immune response.
Right.
And in very specific, severe cases with a poor prognosis despite standard therapy, autologous stem cell transplantation, ASCT, might be an option. But that's a major procedure.
Stem cell transplant, okay. And then drilling down into the specific organ problems, how is that managed?
Exactly. Management has to be tailored to the organ involved. For Raynaud's and digital ulcers, beyond general measures, we might use calcium channel blockers like nifedipine, maybe ACE inhibitors, SSRIs, IV prostanoids in severe cases. For calcinosis, antibiotics if infected, some drugs might help dissolve them, sometimes surgery if they're really problematic.
Okay.
Musculoskeletal symptoms, pain, inflammation might need immunosuppressants, sometimes surgery for contractures. GI symptoms depend heavily on the problem. PPIs or H2 blockers for reflux, prokinetics for poor motility, nutritional support, antibiotics for SIBO, fiber or specific meds for constipation diarrhea.
Very targeted approach.
Yes. For pulmonary fibrosis, ILD, immunosuppressants like cyclophosphamide or mycophenolate, and newer antifibrotic agents are emerging. Pulmonary arterial hypertension has its own specific drugs. Endothelin receptor antagonists, PDE5 inhibitors, prostacyclin analogs.
Specific PAH drugs, right?
Renal crisis is an emergency needing aggressive ACE inhibitor treatment, possibly dialysis. Cardiac issues are treated based on the specific problem, standard heart failure management, arrhythmia treatment, etc. Erectile dysfunction can be treated with PDE5 inhibitors or prostaglandin injections. The key message is management is highly individualized based on subtype, disease duration, and exactly what organs are affected.
It really underscores the complexity. Given all this, what's the typical prognosis? What can patients expect long-term?
Prognosis is quite variable, really hinges on the extent and severity of internal organ involvement and complications. Early diagnosis and intervention definitely help improve outcomes. But, it is a chronic, often progressive condition, and significant organ damage does impact the long-term outlook.
What do the numbers generally show?
On average, the 5-year survival rate is around 75%, maybe dropping to about 62.5% at 10 years. The major causes of death tend to be pulmonary fibrosis and pulmonary arterial hypertension.
Those lung complications again.
Yes. And even after a renal crisis, while 1-year survival is okay, maybe 70–80%, the 5-year survival drops significantly, perhaps 50–60%. So these numbers really highlight how serious the condition can be.
Absolutely. Finally, let's just recap the potential complications. What are the key problems people might face?
We've touched on the big ones: pulmonary hypertension, interstitial lung disease, renal crisis, also severe GI dysfunction leading to malabsorption or obstruction, various cardiac abnormalities, painful digital ulcers that can get infected. It's also worth noting a slightly higher risk of certain cancers, lung, breast, hematological. Coexistence with other autoimmune conditions like Sjogren's syndrome is possible too, causing dry eyes and mouth.
Other potential issues.
Yeah, things like depression, which is understandable, osteoporosis, hypothyroidism, and pregnancy presents unique challenges.
Right. You mentioned pregnancy. How is that managed?
Successful pregnancy is possible, especially with stable disease, but it needs very careful planning and close monitoring by a specialist team. Terogenic meds, drugs harmful to the baby, must be stopped beforehand. Reflux often gets worse during pregnancy.
Are there specific risk factors in pregnancy?
Yes, pre-existing PAH, severe organ involvement, or rapidly progressive diffuse disease increase the risks. And while ACE inhibitors are vital for renal crisis, they have to be used very consciously during pregnancy due to potential fetal harm. So it's a tricky balance if a crisis occurs then.
A lot to consider. So bringing our deep dive to a close, systemic sclerosis is clearly a really complex, multifaceted autoimmune condition. Early recognition, accurate diagnosis, and that coordinated multidisciplinary management seem absolutely crucial.
That's the takeaway, absolutely. Understanding the differences between limited and diffuse, knowing the key autoantibodies, being aware of the potential complications, all vital for revision and for clinical practice.
Definitely. We hope this detailed look and maybe those mnemonics help cement this topic for you as you revise.
And just as a final thought, considering the sheer range of ways SSc can affect the body, what single aspect do you think ultimately has the most profound impact on a patient's day-to-day quality of life? Something to perhaps mull over.
For more in-depth revision resources and helpful materials, be sure to check out passthemsra.com.
And for additional free learning materials to support your studies, you can also visit freemsra.com.